So I'm going to speak about one particular disease which is called Peripartum Cardiomyopathy. It's an idiopathic cardiomyopathy presenting with heart failure, secondary to left ventricular systolic dysfunction towards the end of pregnancy or in the months following delivery, where no other cause of heart failure is found. And it's a diagnosis of exclusion with an ejection fraction which is nearly always reduced to less than 45%. And usually the heart is dilated, but also not always. And this definition is based on a position statement which has been published in the year 2010, and Eckhard Buchmann is also one of the co-authors. So when do the patients present? Why is this definition now sort of more vague than the previous definitions? And the reason for that is that the majority of the patients present within 4 months postpartum. However, there are clearly women who present earlier than 1 month after delivery, and there are also women, about 10%, who present or are only diagnosed 6 or 7 months postpartum. The complicated part with peripartum cardiomyopathy is that symptoms can be very subtle to dramatic, and they can vary. The most common symptoms are dyspnea, and the patient can present in function class 3 to 4, cough and fatigue, but there are also less common symptoms and more subtle symptoms, and that's why the diagnosis is often missed. So according to the position statement of the European Cardiac Society, the workup for women with suspected peripartum cardiomyopathy should include an ECG and a brain natric peptide and echocardiography. If there are any abnormalities, the patient should be referred to the cardiologist. If all is normal, it's more likely that there is another cause of the shortness of breath. There is a very large differential diagnosis to peripartum cardiomyopathy. I don't think it's such a problem in South Africa. It's a disease which is well known, and many students and many housemen will see at least 1 or 2 cases. However, that's not everywhere in the world. And it's often confused with or not diagnosed, and due to the large differential diagnosis, which include a pulmonary embolus, also presenting with shortness of breath, pre-existing idiopathic dilated cardiomyopathy, pre-existing valvular disease, as Professor just highlighted, mitral stenosis, hypertensive heart disease in patients who present postpartum, and pre-existing unrecognized congenital heart disease. Echocardiography is of fundamental importance. First, to make the diagnosis of peripartum cardiomyopathy. You see usually a dilated but definitely impaired systolic function. The mitral regurgitation is a marker of poor outcome because those are the patients with a more dilated heart. Pulmonary hypertension is important to document. It's also a marker of a poor outcome. And there are other criteria which are under research at the moment. How common is the condition? It's 1 in 1,000 in South Africa, and estimated to be 1 in 3,500 to 1 in 15,000 in the United States. It's quite interesting that there are no prospective data from Australia or Europe. However, that's changing. I know a number of manuscripts about preparation on press that the disease definitely occurs worldwide, and there are also papers from Japan now, from India, and from many other regions. A very recent publication, Elena will know it well, looked at the predictors of outcome in 176 patients with peripartum cardiomyopathy. And you can see in blue that 111, where's my mouse? Oh, here. That 111, so the absolute majority of the patient is not normalizing their systolic function. There is still a large percentage, about 20%, it depends on the registry and how closely you look, about 15 to 20% of the patients die. And normalization of the ejection fraction, which is a marker of contractility of the heart, is only achieved about 30% of the patient. So what is the etiology of this disease? There were a number of different hypotheses, but perhaps I should quickly go back. So what is happening in normal pregnancy? You develop a pregnancy-associated hypertrophy. It's very subtle, but it's important to accommodate the increased cardiac output which is necessary in the pregnancy. And in the majority of the women, the heart returns to normal via the activation of protective cardiac signaling pathways. However, in a certain percentage of women, they develop a peripartum cardiomyopathy, which, as I said, would also return to normal. Patients can die or develop irreversible dysfunction. A number of researchers looked at viral antigen persistence, stress-activated cytokines, autoimmune responses, micronutrients, increased myocyte apoptosis, and the two factors which seem to be really causally involved are genetic factors and the role of prolactin. Early in our effort to try to understand the disease, we actually found one particular marker to be upregulated consistently, and that has also been confirmed by others, which was a marker which is standing for apoptosis, fast APO1. And that marker also highlighted together with interferon gamma and prolactin those patients who do have a chance of who do not recover their systolic function. In the year 2010 and subsequently in 11, two other papers were published showing rare variant mutations in peripartum cardiomyopathy. And we know now from a number of papers that screening of family members in patients with peripartum cardiomyopathy is advisable, and that if you look carefully enough, about 10 to 15% of family members of patients with peripartum cardiomyopathy will either have a sister or mother with a peripartum cardiomyopathy or brother with a dilated cardiomyopathy. A recent publication from the beginning of this year looked at circulating microparticles as an indicator of peripartum cardiomyopathy. I'm not going into depth into what a microparticle or microvesicle is, but just very briefly, there are vesicles which are released from cellular membranes during cell activations and apoptosis, explaining why this marker has been found so consistently upregulated. And they also may play an important role as bioactive molecules in peripartum cardiomyopathy. And this paper actually highlighted that there is a very specific pattern of endothelial microparticle which is distinct for peripartum cardiomyopathy if it's compared to dilated cardiomyopathy, ischemic cardiomyopathy, non-pregnant women and pregnant women with preeclampsia, which showed a very certain pattern on monocyte-derived particles, platelet-derived microparticles, and the others. But I have no time to go into that. So where are we standing now with the other concept that prolactin might be causative or having a major role? Postpartum, it comes to an activation of prolactin via a receptor on the cardiomyocyte, which leads to an increased oxidative stress and an upregulation of cathepsin D. And this cathepsin D is actually leading to the conversion of the normal 23 kilodalton prolactin to an abnormal 16 kilodalton prolactin, which is responsible for endothelial cells dissociation, prevention of capillary formation, apoptosis leading to peripartum cardiomyopathy. We are fortunate that there is a medication available, bromocriptine, which is inhibiting the prolactin altogether. And we have tested that in a very small proof of concept pilot trial using bromocriptine in patients with newly diagnosed peripartum cardiomyopathy. And what we could show that in the women who received the bromocriptine was a marked improvement in the systolic contractility compared to the patients who remained on standard therapy, which included the ACE inhibitor and the beta blockers. There was also no difference in the outcome of the offsprings because we managed to provide formula milk to the children, the mothers who could not breastfeed subsequently. So ideally, you want, if you show a proof of concept trial, you want to confirm your data in a larger trial. And there are a number of researchers, not only in South Africa, but mainly in Germany and in other European countries, who got ethic approval, got the funding, who started to do a randomized trial. However, it's not easy to do a randomized trial in that particular condition, in particular because you can't blind the treatment to bromocriptine. Everyone will know that the breastfeeding stops one day later. So it's not possible to do a blinded trial. And here you see the disadvantage or the consequences of Google, internet, patients getting more informed. all the 3 trials struggled to find patients who wanted to be on the placebo arm, because women found in the internet there is a benefit on bromocriptine. So the authors of this paper, which is now submitted, converted actually their data into like a registry, and you can see that the patients who received the bromocriptine, there were only 4 who belonged to the group of the non-improvers, whereas the group who decided to not have bromocriptine, which was much, much smaller, there was a larger number of non-improvers. So that's the only other evidence we have. Based on the concept which we postulate, we do not recommend breastfeeding in women with newly diagnosed peripartum cardiomyopathy. So what are now the next step? Peripartum remains a difficult condition to be diagnosed and treat. Prior definitions emphasizing on strict time window and echocardiographic cutoffs like dilatation or no dilatation are likely to have led to conditions being overlooked or misdiagnosed. The symptoms can mimic many other conditions, and a high index of suspicion is warranted. Treatment with standard medication bromocriptine should be investigated in larger trials. However, that proves to be difficult, but I show you what is the alternative. And we need to identify biomarkers to facilitate early diagnosis and predicting outcome, and that research is underway. So with the last 2 slides, I want to create awareness. We, together with 20 other collaborators, we created actually a platform which is dedicated to women from lower educational background in particular, to learn about cardiac disease and pregnancy symptoms, and also to healthcare workers. There is also ongoing registries now in South Africa, in Cape Town, and in Africa and ESC affiliated countries, not only on peripartum cardiomyopathy, but also on cardiac disease and pregnancy. And it's important, I mean, South Africa is an ESC affiliated countries, and the guidelines, we're using those guidelines with some modification. So it's important, I want to create awareness that physicians, especially the cardiologists and the obstetricians, are entering their cases into this registry, because first it's an agreement that the participating centers can have their own data, but also it's important that we contribute to the knowledge of various forms of not only peripartum cardiomyopathy, but also cardiac conditions and pregnancy. And I want to acknowledge my colleagues and collaborators. Thank you.